Perfect. Well, good afternoon, everyone. My name is Hong Hao. I'm a third-year medical student at Laval University here in Quebec. And thank you for the opportunity to present our project this afternoon. I have no disclosures, and I apologize in advance for my voice. Okay, so some generalities about PAs. I'm sure this is probably trivial information to you all, but I still included here for completeness sake. PAs are advanced care providers, physician extenders, also called. They practice medicine under the supervision of a physician. They have negotiated autonomy and a scope of practice that have to be discussed with the supervising physician. And they are a major workforce in several countries, including the US, the UK, and the Netherlands, and so on. Some landscape about PAs in Canada. They have their roots in the military setting with the Canadian Armed Forces. They transitioned into civil practice at the end of the 1900s, and they're recognized by the Canadian Medical Association, also known as the CMA. But however, they only integrated in the public healthcare system of only 4 provinces, which are namely Manitoba, Alberta, Ontario, and New Brunswick. So bottom line is that physician assistants, the role of PAs constitute a major workforce in the healthcare system, but they currently have limited presence in Canada. And PAs in surgical specialties, since PAs are trained under the medical model, they are very well tooled to perform diagnosis and management based on the anatomy and pathophysiology. In contrast to nurse practitioners, nursing education, their education model, which is the nursing model, which focuses more on holistic patient care. All that to say that PAs may potentially be better suited for specialty medicine, such as surgical specialties. So the Canadian healthcare system has some unique aspects compared to, for example, the American counterpart. They have a single payer system and have universal coverage for most healthcare services. However, this entails that there's long wait times in Canada. In fact, 30% of Canadians wait 2 months or more to see a specialist, compared to only 6% in the United States. And also 18% of Canadians wait 4 months or more for an elective surgery, when compared to 6% in Switzerland and an astonishing 0% in Germany. And all that is all the more compounded by the unfortunate COVID-19 pandemic, which exerted even additional toll on our healthcare waitlist. And some particularities of plastic surgery. So there's a high prevalence of private practice entrepreneurship in plastic surgery, and which means that there's an increased importance of healthcare resource management versus, say, purely or majoritarily hospital-based specialties. So therefore, it is pertinent and worthwhile to examine PAs with specific respect to the Canadian healthcare system, given its particularities, in order to enable appropriate and tailored decision-making. So the objectives of our study was to revisit current evidence surrounding the impact of PAs on surgical services, as well as to probe the perceptions of plastic surgeons practicing in Canada to evince potential benefits of PAs to their practice. Here's their methods. We searched the PubMed database using keywords, as shown on the slide here. We examined articles pertaining to examining PA's benefits and impacts on surgical services in Canada, as well as plastic surgery services. And we subsequently used the findings of our survey to design an online anonymous survey distributed to plastic surgeons across Canada. Here are some snapshots of our survey. So the results of our literature review revealed that there were only 6 relevant articles examining PAs in surgical services in Canada, with 0 pertaining to plastic surgery specifically. And there were also only 3 articles examining PAs in plastic surgery in the medical literature overall. That only reveals that the literature on this subject is very thin and needs additional efforts. Some findings of our literature review on PAs and plastic surgery to start. So PAs can result and contribute to upskilled productivity of the physician, can contribute to increased patient throughput in the clinic, to decreased operating times of surgeries, to decreased cost overall for the provider, as well as amplified. And all these benefits are further amplified with sustained collaboration. So if a PA collaborates longitudinally with a supervising physician or a surgeon in this case, the benefits were found to be even greater over time. Now, when it comes to PAs in Canadian surgical services, which literature we found were pertaining to orthopedics as well as general surgery, there were also increased operative efficiency and surgical throughput, decreased post-operative times, as well as cost neutrality and potential cost savings, although this aspect wasn't investigated in detail. So the positive findings. So as for discussion, the positive findings from our survey that are to come would imply that PA are acceptable from the surgeon side, which is very crucial since the surgeons are the one who are firsthand interact with the PAs. The survey results will also allow to marry evidence to experience. The survey also takes into consideration the existence of private plastic surgical practices, which may provide a more representative overall picture in Canada, as well as intangible costs, such as that PA potentially being able to spare lower level tasks from the physician, which lead to better well-being and eventually and ultimately better patient outcomes. Also, the trainee, it's also worthwhile to note that the trainee demand for PAs in Canada is very well there, with it being primarily hindered by the lack of training spots. So there's according to one of the CAPA videos, there was 69 spots available for PA training in Canada, with more than 1,000 applications yearly. And with the recent resident duty hour reform, which exerted a limit on the hours allowed by medical residents to do per week, as well as the COVID-19 impact on elective procedures, being which is a big part of plastic surgery, there is ever so a bigger need for other avenues to meet the increased supply and the congestion of patients that currently exist in our healthcare system. And finally, we know that PAs are increasingly capable of performing more, a bigger variety of procedures, as well as a bigger quantity of procedures, and that the potential for improvement with longitudinal collaboration only serves as another argument for an early implementation of PAs, a widespread implementation in our healthcare system. So as for the next steps, the literature review serves primarily as a basis and to build a foundation for our study. And we are currently under work for the nationwide survey, which we're distributing, as well as to perform further economic evaluations pertaining specifically to the Canadian healthcare system to evince benefits. And in conclusion, the findings of our study / our survey will add to the body of evidence backing the benefits of PAs for Canadian healthcare by providing valuable insight for the plastic surgeon standpoint, the surgeons being the party first-hand impacted by the ripples of PAs. I would like to extend a special thanks to our superstar PA, Doris Hansen, present here today, as well as our senior supervisor, Dr. Jaberi, who is currently undergoing his aesthetic plastic surgery training in Spain. Thank you again, everyone. Any question? Yes. Yes. This presentation has not been given to med students, but it's a good idea to consider moving forward when the project matures even more. Yeah, and I think a lot of students are not even aware of the existence of the role. Yeah. Thank you. Yes. So there was the survey, and I didn't discuss it in detail, but the survey is it has 19 items, and covers a broad range of potential benefits that PAs could bring that were found principally from a review. And it asked from decreased if the surgeon think that having a PA could decrease operative times, could improve outcomes, could decrease anxiety or stress levels, could improve resident training, and all these aspects were considered in the survey. So every surgeon, once they access the survey, has access to a brief description of an objective description of PAs, so as to not bias their answer, but at the same time to provide them with a informed brief on PA so that they can answer with properly to the survey. Yes, so this was a point that was indeed considered in our survey, and these answers will be effectively stratified once we have the results. Thank you. Any questions? All right, thanks again, everyone.
Good morning. I am attending virtually from Alberta. I'm just getting my screen share going here. And I just had one follow-up question for you, Hong. I was just sort of wondering if the survey includes inquiry on why the plastic surgeons currently don't have a PA. So what are the current limitations to their practice?
Hey, can you hear me?
I can.
Okay, thanks for your question. So yes, we actually did ask about what are the potential limitations that the plastic surgeons here see when it comes to the implementation of PAs, if that answers to your question.
Yes, it does. Yeah, I think that would just be like a very crucial, just to figure out if it's funding primarily or what. I mean, the desire is there for across the country, but a lot of them is just the logistics of hiring one. So that's good. Thank you.
Yes, I agree. Thank you again.
Yeah. And I just wanted to confirm, are you guys seeing the correct display setting? Are you seeing the notes or are you seeing the actual presentation? If someone can confirm. No confirmation. Okay. Oh, we have some in the chat. Okay. I just changed it and I don't know what the timing of the message. We're seeing the notes now. We're good now. Excellent. Okay. The joys of virtual presenting. Thank you. All right. Well, again, thank you very much. Sorry, I'm not there in Quebec. My name is Natalie, currently working in otolaryngology, head and neck surgery, or ENT, at the University of Alberta in Edmonton. And I'm going to discuss a study that I had done this year. I'm just gonna, how do I get rid of that guy? There we go. Entitled Outcomes in Perioperative Knowledge and Discharge Readiness Following Postoperative Text Message Protocol Implementation in Head and Neck Cancer and Free Flap Reconstructive Surgery. My slide's not advancing. Okay, down here. There we go. All right. So 80% of our population utilizes text messaging, and text messages have been shown in healthcare to empower patient self-care, improve outcomes, and provide patient education. Within otolaryngology, text messaging has already been utilized in post-tonsillectomy education, reducing clinic non-attendance, recruitment for cleft lip palate surgery, smoking cessation in head and neck cancer, and adherence to allergic rhinitis treatment. Following major head and neck surgery with reconstruction, patients require a surgical airway until they have adequate airway function. And unfortunately, having a tracheostomy tube will disallow phonation, which is challenging for both the patient and provider, and could be quite frustrating when we have to watch them write in order to communicate with us. So perhaps text messaging might be an easier form of communication for patients with a new tracheostomy or laryngeal stoma. With permission from patients, here are a couple of pictures that I just like to show you of sort of what our population looks like. So this woman on the left, we can see that she's undergone rhinectomy. So we have removed her nose. And then this here is a piece of her thigh, actually, that we've utilized to reconstruct the nose. And then this here is her nasogastric tube that's going into the nasopharynx and then down. And unfortunately, you can't see, but she does have a tracheostomy tube down here. As you can see, that it would be quite challenging for this woman to breathe initially out of surgery. And then obviously you can see that vision would be impacted as well. And then on the right, this is a patient that has undergone laryngectomy. So here we have a laryngectomy tube that's sitting into the anterior neck, and this is what they breathe out of. And this is not contiguous with the rest of the upper airway. So they do no longer breathing through their nose and mouth here, but straight through the neck. And then we can see that following the cancer resection, we do have a bit of a mucky wound, but again, this is another considerable sized free flap. So again, you can see how communicating for this patient would be challenging as well. Text messaging in the early postoperative period following major head and neck surgery has yet to be examined. However, we do know that high quality discharge education leads to increased preparedness for hospital discharge. So with these in mind, the objective of our study was to develop and evaluate a text messaging protocol to improve readiness for hospital discharge following major head and neck surgery. Adult patients following surgery were recruited and randomly assigned to either the control or intervention group. The control group received no text message communication, undergoing the current standard of post-hospital care, and then completed a discharge readiness survey at the time of discharge. And then the intervention or the text message group underwent the protocol, which I'll outline in the next slide. And then they also filled out that same discharge readiness survey. The text message group received standardized text messages from a physician assistant, myself, at the following in-hospital events: transfer to the ward from an observation unit or sometimes the ICU, depending on their intraoperative and early postoperative course; at the time of tracheostomy or laryngectomy tube change; at the time of its removal, if applicable. So we, of course, would never remove a laryngectomy tube because that's how they breathe, but patients with the tracheostomy tubes, ideally that tube is removed at some point after surgery. So I texted them on the removal of that tube. The removal of their donor site dressings and Doppler wires. We placed Doppler wires beside the flap to allow us to hear whether or not there's adequate arterial and venous flow. And then at the time of hospital discharge. Also in this text message protocol, the patients could text me between 12 and 1 o'clock to receive independent responses every day. So the primary outcome measures of this text message study was the readiness for hospital discharge. Secondarily, I looked at the length of hospital stay, 30-day readmission rate, and postoperative morbidity. Because the data was not normalized for our continuous variables and survey data, we utilized a Mann-Whitney U test. For the categorical variables, a Fisher's exact test. SPSS version 26 was utilized for all data analysis. So we had 28 patients, but in total 26 were recruited because 2 of the text message group patients were excluded due to refusal of participation. So 12 in the text message arm and 14 in the control arm. So this is the data for the patient demographics. I'd like to point that there's no significant differences in any of these patient demographics, though there was a trend for the text message group to be nearly 10 years younger than the control group. Notably, I would like to state that there's no differences in the tumor site, so either oral cavity or oral pharynx versus other sites, the stage of the cancer, or their Charleston comorbidity index. With respect to their postoperative in-hospital course, again, there were no significant differences between the 2 groups. Notably, no differences in the postoperative complications, which could account as flap or neck dehiscence, a subcutaneous air leak, hematoma, delirium, false tracheostomy tract, acute airway obstruction, or hemorrhage. There were no significant differences in the requirement to take back to OR. And we can see that we actually have, this is interesting, that we actually have quite a high of return to OR for complications related to the flap. So they're very sick individuals. There was no difference in the number of days to decannulation, so 8 versus 9. And then again, no difference in the postoperative day at discharge. And we can see that the average hospital stay is about 2 weeks for these patients. There were 2 deaths in the control group, and no differences in postoperative morbidity in terms of having to go home with either tracheostomy or gastrostomy tube. With respect to the discharge readiness, we were surprised. However, there were no significant differences between the 2 groups. These are not all the questions on the survey, but this sort of highlighted some of the one of the main ones, sort of the meat and potatoes of it, what I thought, where we asked, how physically ready are you to go home? Emotionally ready? How would you describe your physical ability to care for yourself? How much you know about the problems to watch out for? How do you know about caring for yourself? And how well will you be able to handle the demands of life at home? And 10 being more positive, we can actually see that the patients, it was good. They do feel somewhat ready to go to go home after the 2-week hospital stay. This is a table of the text messages that were sent and received between the patients. So we can actually see that some patients didn't really engage at all with no text received, and then some were quite happy to communicate with me. I think that I would like to, on this slide, just sort of point out some themes of the text that I received. Most often frustration with diet advancement. Some of them were reassurance seeking, talking about discharge, wound care arrangements, medication questions, general thanks for the updates. So a quote that I would like to share with you was that I was able to get down the pureed food, but it was frustrating it took so long. So I think it was just sort of interesting just to see sort of the themes of the texts that I was receiving. So overall, 94 text messages were received, 157 of them were sent by me, and 72 of those were automated. We were really impressed that 75% voluntarily expressed satisfaction of the text messaging. I considered this a great resource while being here, said one patient. This text message study is totally amazing. Thanks for providing service. I appreciate the communication. And I like this last one. Thank you with the smiley face emoji. You're the best. So overall, this is the first study to our knowledge that utilized text messaging in active head and neck surgery in patients. This was a pilot study that aimed to assess the feasibility of the protocol and therefore was not powered for significance due to its limited sample size. As well, we did not assess the influence of text messages on the hospital stay and their satisfaction, but we do know that patients liked the text messages, and it would be great to quantify the patient satisfaction in future studies. Perhaps some of the inpatients were just too ill to engage. You saw those photos, they're massive surgeries, and they're in hospital for 2 weeks. So maybe providing education passively, either in a video or an app, might be a better means of communicating. And 2 of the patients actually preferred for their family members to communicate. So I was often talking to the spouse instead. The text messages often were just sought generalized information, or they were reassurance seeking. So in terms of providing education, I'm not quite sure if that was, the patient's main goal was to receive information, but really just have that extra outlet for them. There was a lot of venting, often with some sort of nursing complaint or something, which was also quite interesting to read. And then this was also very eye-opening for me when at the time of discharge, I was giving post-operative education, follow up with the cardiologist regarding these new medications. And he writes, I had a heart attack, news to me. So this really shows us that there's a gap in educating our patients about significant in-hospital events. So we acknowledge some limitations of the study being that we didn't assess satisfaction, and nor did we assess the likelihood of text. So maybe age or marital status would influence a patient to text or not. And again, as mentioned, this was underpowered. However, it was a feasibility study. In the future, we would like to quantify our qualitative data and create a formalized teaching, either via standardized text messages or an app moving forward, or perhaps we just blast text messages as a standard of care for our free flat patients. So in conclusion, text messages are a feasible option for patient education and engagement, and it may be a novel avenue towards increasing patient satisfaction and potentially improving outcomes. Those are my references, and I thank you very much for your attention this morning, and welcome any questions.
Hi, Natalie. That was a really great presentation. I loved it. Was this an idea that you came up with on your own?
It was, yeah. It's really frustrating at 6 a.m. rounds when you have to see 28 patients that don't talk and they're writing like a word a minute. And some of our patients are illiterate as well because of the population that we serve. So it was quite an obvious idea for me. Mm-hmm.
Is this going to cost anything to continue it, or do you think it's something that you can carry on?
Good question. I'm going to apply. There's actually a CPSA grant that I was just notified of the other day, which provides $5,000. So I hope that I can get that to maybe support this. For the meantime, the division, I had an old iPhone, so it was quite a low cost study, which was really great. So for a minimal cost, I got a new SIM card with an old iPhone, and then it just took a little bit of time.
Hi, Natalie. It's Sharona Kanofsky. How are you?
Thank you.
Nice to hear this presentation. My question is, wouldn't it be interesting also to see what clinicians, what their perspective on using this? Because I guess how many clinicians were using the texting feature?
It was just
you?
myself.
Yeah. So is this something that you're considering, having a few other clinicians and getting the perspective? Because we see it seems from the patient's view that they like it. It's a good option. Why not? Better to have it than not to have it, kind of thing. But what about whether it adds to your ability to care for your patients, and not just you, but other clinicians?
That's a great idea. Yeah, we have for all of our patients, occupational therapy, physical therapy, respiratory therapy, and speech language physiology. They're all, or pathologists, they're all used. That's a really good idea. And I wonder if that would be more app based, where everyone can versus a bunch of text messages that could get overwhelming for the patient. But maybe if it's one centralized area, then everyone could contribute. That's a great suggestion.
Hi, Natalie. Lee Spencer. Quick question. How does AHS view this from a legal standpoint?
Yes, ethics was obtained from the University of Alberta. So I did have a lot of questions that I had to mitigate in terms of the privacy. So basically, I'm not allowed to have any saved phone numbers and whatnot, but I did have permission to receive their phone number. And then so long as I did not share that and there was no personal health information actually distributed beyond the cell phone, then they were okay with that. So it was more from U of A as opposed to AHS, but this did receive RAB acceptance.
Excellent. I know we use it as a point. We do use it within my service as well, between the clinicians. But the data on there is very minimal. It might be a room number or a bed number, no identifying features whatsoever. So I think it's a great platform. I think what you're doing is a great thing, and hopefully we can get that into the healthcare system because it does expedite everything. Thank you.
Thanks, Lee.
Anybody else?
Okay, I think that's it, Natalie. Thank you so much.
So sad I'm not there. Enjoy the rest of the conference, everyone.
Well, comes to an end again. On behalf of Kevin Dixon, he has unfortunately had to leave early. I'm going to be doing your farewell closing remarks. So these are actually Kevin's words. I'm just saying them on him for him. So we made it. Another successful conference is coming to a close. And we hope that you have enjoyed your learning sessions, your network opportunities that this weekend has been able to offer. Firstly, I'd like to thank you all for joining us here in Quebec City. We'd also like to thank all the speakers for their excellent and thought-provoking talks. I'm very happy, and I echo these words with Kevin, that the last 4 days have exceeded even our most optimistic expectations in all retrospects, and during the sessions, during the network break, socially, during the welcome reception and the awards ceremony. I know there were a few little glitches with the Zoom, and this really is our first hybrid conference that we've held. So we take the feedback for next year. We once again congratulate all of our award winners, and we hope you are inspired by Dr. Ozon. Sorry, he was my teacher. And we also hope that you reflect on what Jamie Baptiste, the MP in Nova Scotia, had to say when he says, well, other MPs may refer to this being a provincial issue. There is a federal MP who has been advocating for us within the Liberal government, and we've given him our honor roll. So if he can do it, challenge your MPs on why they can't do it. I hope the contacts that you've made here have been with your fellow PAs will continue in the future, as they can be invaluable and lifelong. Once again, thank you to the Planning Committee and to all of our sponsors and exhibitioners for supporting the conference, and most importantly, our PA profession. CAPA 2023 will be held in Fredericton, New Brunswick. And if you're interested in being part of the planning committee, please contact the CAPA office staff. We want 2023 to be a huge success, and we want to get started planning early to make sure that this happens. So please, I really encourage people, you know, in years past, we only get 4 or 5 people that want to plan our conferences. And the more people that can be on the planning committee, the easier the job is for the planning committee. Keep in mind, Fredericton only has 3 PAs. So we really encourage as many people to come out and help them out. Our conference is by PAs for PAs, so save the date. It's October 19 to October 22nd this year or next year. As a reminder, if you've not already done so, do not forget to complete your session evaluations. You will find a complete conference evaluation form on the CAPA 2022 website, and we welcome your feedback, especially this year when we've had a hybrid event. We want next year to be even better. And that's it. It's over. Thanks. Safe travels.